good afternoon, and good evening, depending upon where you are joining us from. I'm Dr. Vijay Agarwal. I'm president of CAHO, and it is my pleasure to welcome the ISQua leadership, our distinguished speakers, guests, and participants on behalf of the CAHO patrons, governing committee, and the entire CAHO family. It is a privilege to welcome you to this celebratory international webinar making 5 impactful years of partnership between CAHO and ISQua. A collaboration which is built on shared values and a common commitment to advancing quality and patient safety globally. Our monthly webinars on the first Tuesday have evolved into a vibrant international learning platform, with participants from over 20 countries reflecting the strength and relevance of this partnership. In parallel, CAHO has designated the first Tuesday of every month as the monthly quality meeting days across the hospitals in India. Through this initiative, hospitals are encouraged to share good practices and engage nearby small and medium healthcare organizations. And I'm pleased to share that more than 40 hospitals are already observing this, translating into action. For CAHO, ISQua has been more than a partner. It has been a guide, a collaborator, and a catalyst, inspiring us to move beyond compliance and accreditation towards a culture of continuous improvement and patient safety. As we look ahead, let us remember that accreditation is not the destination, but the beginning of the quality journey. CAHO's call has been to remain accreditation ready on any given day, embedding safety into everyday practice. In this context, today's webinar on medication safety is especially important, as medication errors are largely preventable and eliminating them requires shared responsibility, strong systems, and collective learning. Let us take today's conversations back to our organizations and work together to make patient safety a lived reality, every day, everywhere. So thank you and a warm welcome to all of you. Thank you so much.
Thank you, Vijay sir, and it's a pleasure to invite Dr. Karsten to give his address. Dr. Karsten is the CEO of ISQua, and we really appreciate the ISQua leadership for joining. Dr. Ezekiel is also here. Over to you, Dr. Karsten.
Thank you, Dr. Lalu. Dear friends and colleagues, it's a great pleasure for me to attend the webinar today that marks the 5th anniversary of the ISQua CAHO International Webinar Series. For 5 years, these webinars have been a monthly recurring event that has contributed significantly to raising the awareness of quality and patient safety issues and has contributed to building capacity and engagement not only in India, but in the wider region and in other regions of the world too. We have covered a broad range of subjects, from traditional patient safety topics such as medication safety and incident analysis, or clinical governance and patient engagement to AI, just to mention a few. We, as Dr. Agarwal expressed it, also subscribe to the philosophy that accreditation is not an endpoint. It is not about getting a certificate, hanging it on the wall and then relaxing. On the contrary, it's the beginning of a journey. Accreditation will help you and continually support you in building and maintaining a resilient organization that's capable of and committed to improving the quality and safety of the services they deliver all the time, based on evidence and data, leadership, and staff and patient engagement. And from that perspective, it's very good to see that numerous organizations have made the ISQua CAHO webinars an occasion to bring people together and to learn together. Of course, we also welcome those of you who come on your own, but remember, this is not just about improving you. Share what you have learned and the ideas that have been triggered by the webinars in your organization. As the saying goes, you have 2 jobs. One is to do your job, the other is to help improve your organization. I would like to express my sincere gratitude to all the ISQua academicians, ISQua experts, and other renowned experts who have been willing to share their experience by giving their time to prepare and speak at a webinar. Some of you are present here today. Your willingness and efforts are highly appreciated, and I'm happy to say that there has been a great interest in presenting in 2026, so we can look forward to another exciting year and hopefully to many more. Finally, I would like to announce that CAHO-Con 2026, taking place on the 10th to 12th April in Chennai, will be branded as an ISQua Regional Conference for South Asia. This is the first South Asian regional conference of ISQua. It is a landmark moment for Indian healthcare, and we are proud to join CAHO's global journey by taking this step. With this, once again, congratulations. Thank you to everyone who is attending today, and over to you, Dr. Lalu.
Thank you so much, Dr. Carsten. Truly momentous occasion for us. We appreciate the leadership of ISQua for joining hands with us and for promoting quality and patient safety in the region. We really look forward to all your speakers, your experts, and you and the president of ISQua joining us at CAHO-Con 2026. Let me take a few moments to take you through the journey of the beautiful 5 years of our relationship with ISQua. It's been a great partnership, and I must acknowledge and thank Dr. Peter Lackman for initiating this partnership. Thank you. Amazing. What an amazing experience with all these speakers. We started with Dr. Eyal Zimlichman, and we've had 60 speakers internationally renowned, excellent speakers, excellent sessions all over the globe. I think they've represented every continent. Thanks to ISQua and the ISQua Secretariat for bringing all of them together to the audience in India and the region. Next slide, please. Rita, can you move, please? Yeah, these are the speakers. They engaged with us, our audience. They answered to all the questions and beautifully moderated by the moderators from India and the region. We have had several moderators who have given their time, their expertise to moderate the wonderful sessions by the ISQua speakers. Yeah, so we have covered 30,000 attendees. Imagine in the last 5 years, we've had 30,000 people attending the CAHO-ISQua International Webinar Series from 25 countries. And we have listed out all the countries from where the participants have attended this international webinar series. Thanks to all the participants for joining us from all over the globe. And that clearly shows the impact of the international webinar series that we've had in the past 5 years. Next one, please. Yeah, so these are some of the topics. Keep going. Yeah. And as Dr. Agarwal said, we've had our Centers for Quality Promotion having these international webinar series in their boardroom, from their auditorium, to attending to many, many small and medium hospitals across the region. So these are some of the flyers that they circulated. Every month, we have at least 40 Centers of Quality Promotion of CAHO joining from their hospitals with their entire audience. Next one, please. And I must really thank the wonderful feedback that we have received. 95% of the participants have rated the international webinar series of CAHO as excellent. Amazing job done. Thanks to all the speakers. We have got some of our patrons joining us today. And I thought, let me ask our patrons and some of the speakers just a couple of questions about what they think about this partnership, about the webinars that we have had. Let me first open to Professor Dr. Ravindran Jagasoti. He's been instrumental in, moving. He's been the chair of our CAHO International Advisory Committee. We thank him for getting all the international audience and the best practices sharing from across the region. So, sir, to you, what does this 5-year milestone mean to you, Professor Ravindran?
Yeah, it's a very historic day for me. I remember being here on that first session And now 60 sessions later, I'm still around in a different capacity. I think what has happened is CAHO has started learning from the world, and soon the world will learn from CAHO when you come for the regional conference. I think that is what is happening.
Thank you.
Thank
Thank you, sir. Beautifully said. I'll now move to Dr. Air Marshal Dr. Pavan Kapoor, patron of CAHO. And I think he's attended probably 70–80% of the international webinar series that we have had so far. Sir, why are global partnerships like ISQua important for Indian healthcare?
Okay, firstly, I think I must wish all of you a very happy new year. And I must congratulate both CAHO and ISQua, and I'm a very, integral part of both the organizations. I have been with ISQua since 2012 and with CAHO since its inception. Now you see this partnership between ISQua and CAHO. It has exposed the Indian healthcare system to a lot of international best practices, to what is happening around the globe. So it has actually lived true to the saying that quality knows no boundaries. There are no national, no international, no regional boundaries. And that is what ISQua has brought to CAHO. So it has exposed the Indian healthcare delivery system to all international best practices. It has helped Indian healthcare delivery system to imbibe those practices. It has also helped ISQua to take home certain good practices from the Indian healthcare delivery system and then use it wherever they feel in their various standards, make it applicable to the rest of the globe. So I think it is a symbiotic relationship. Normally, I say that we have a psychological relationship, but this is a symbiotic relationship where nobody is psycho, but everybody is logical. So thank you very much. God bless this relationship. And I wish to see that 25 countries become 250 and 30,000 becomes 300,000.
Thank you. Thank you so much.
Thank you.
I will move to Dr. Ezekiel, the president of ISQua. Dr. Ezekiel, how would you reflect on the impact of CAHO-ISQua partnership over the past 5 years? Firstly, thank you. Thanks a lot for continuing with this webinar series and your answer.
Well, thanks again. Thanks for having me today. Well, greetings from Buenos Aires in the morning. I would say, Lalu, that I'm totally amazed about what CAHO has been doing in the region. It has been an example for Southeast Asia, for also for the rest of the world, how the motivation for quality patient safety can impact your region and the rest of the countries around you. So it's a privilege for ISQua to collaborate with you. We are fulfilling our mission to contribute and synergize with organizations like CAHO and trying to bring quality and safety to everyone around the world. So congratulations on this celebration, and please count on us for the future. Thank you.
Thank you so much. Truly appreciate Dr. Ezekiel. Alexander Thomas, the patron of CAHO. Sir, what has made this collaboration sustainable and meaningful? What do you think?
Yeah, thank you, Lalu and Vijay. First of all, a very blessed new year to all of you. And congratulations to both CAHO and ISQua. Though I have not been a very active part of this webinar series, I know how much work and effort, and most importantly, the impact it has created. It is a milestone day today when you have finished 5 years, and once again, congratulations. Looking back from where CAHO started, I'm very gratified that we have grown so much. And to answer your question, Lalu, I think it is the leadership team and the team that you have created, which is really making a wave. And may God bless CAHO, may God bless ISQua, and may you continue to impact millions of lives, not only in India, but all over the world. Keep up the great work.
Thank you. Thank you so much, sir. I'll move to a couple of speakers who are here with us. Dr. Hans, I see Dr. Hans here. Dr. Hans, what do you think? How do such webinars support practical quality improvement in the region?
Hello, Dr. Lalu. I think you're addressing me.
Yes, Dr. Hans. Yeah.
Could you please repeat your question?
How do you think such webinars support practical quality improvement in the region?
Thank you for your question. Thank you also for the invitation. It's great to be a part of this celebration, which is very special to me. As you know, probably I work in the field of environmentally sustainable health systems. And yeah, this is a great challenge, of course, adopted by ISQua, since this is also a matter of quality and safety in our health systems. And it's also adopted by CAHO, since, yeah, India suffers from ecological damage, as we all know, also recently. And I have seen great changes of greenifying, so to say, the healthcare routine in India. And yeah, it is a long way to go. I mean, quality improvement is a daily process, and yeah, collaboration, of course, is key for this. And sharing knowledge via this organization and this collaboration is very essential for improvement, the patient safety and quality in healthcare. Thank you.
Thank you. Thank you so much. To the last question, Professor Eva, are you available? Yes, Professor Eva, what value do international knowledge sharing platforms like CAHO and ISQua, what do they offer to the globe, the audience, the quality professionals, and the clinical domains?
Thank you for your question, and thank you also for the invitation. I was delighted to receive it. I think what you are doing with these webinar series is, as has already been said, opening up areas of expertise to the whole community of healthcare professionals in India, which is so impressive. And I think the one thing that struck me personally when I was delivering the webinar was the number of people who attended. And, you know, you get such huge attendance numbers, certainly from our perspective, you know, we wouldn't get that kind of level of attendance in that kind of a webinar. And I think that speaks to CAHO and the respect that everybody gives to it and what you're trying to achieve. And, you know, the whole thing here is to get the message out to as many people as possible, and so that we're all talking the same principles, and you know, we're all on the same page, as they say, and I think that is what this webinar series has really working to achieve. It was really impressive. I was very proud to be part of it, and to know that, you know, it reached so many people. I mean, I remember seeing the thumbnails of just one contact, but there would maybe, I don't know, there was like 20 or 30 people in the room. You know, that's just incredible.
Thank you. Thank you, Professor Eva. I want to take this moment to thank a very special person, Dr. Anuradha Pichumani, for the support extended for this partnership between CAHO and ISQua. And it's been amazing support that she's been rendering along with Sakshi, getting these webinars moving. Thank you, Anu. Thanks a lot for the support extended, and we really truly appreciate you for your efforts.
Thank you.
So I would like to acknowledge the presence of several of our International Advisory Committee members, our patrons, of course, Dr. Peter Lackman, who's joined us. Thank you, Dr. Peter. He is now the chair of our International Advisory Committee. Dr. Shin Ushiro, John Yoon, Dr. Vishnu Panigrahi, Dr. Anup Warrior, Dr. Palicha, Dr. Yatish, Dr. Gary, and all the other Ilom, Dr. Ilom, I see Dr. Ilom here. Thanks a lot for joining us, and let me extend a warm welcome to all of you for CAHO-Con 2026 at Chennai. We will treat you well. Please join us. Over to Dr. Vijay Agarwal to take the session forward.
Okay. Maybe a brief comment from Dr. Muralidhar. I think he had been writing a couple of times before I introduced Dr. Subhrojyoti. Is Dr. Muralidhar? Are you there? Okay. So it's my proud privilege today to introduce the moderator of today's session, Dr. Subhrojyoti Bhowmick. He is a very well-known face to the, at least to the entire CAHO fraternity. He is a distinguished clinician, academician, and a leader in the medication safety and healthcare quality. He holds an MD in pharmacology, is a fellow of ISQua and India's first Lucian Deep Patient Safety Fellow. With global exposure at WHO Geneva and Harvard Medical School, he currently serves as a professor of pharmacology at the KPC Medical College, Kolkata, and chairs multiple institutional ethics committees, contributing significantly to the patient safety and healthcare systems improvement. If I were to read about all his biodata, I think I'll be encroaching upon the time of the speaker. So over to you, Subhrojyoti, to introduce to the speaker of the day. Thank you.
Thank you, Dr. Agarwal, Vijay sir, for that kind introduction, and good evening to all the people who are joining today's historical webinar. It is my pleasure that on behalf of CAHO and the International Society for Quality in Healthcare, ISQua, I extend a very warm welcome to you. And as Dr. Lalu was mentioning, that we are celebrating today's 5 years of strong partnership between two great institutions, CAHO and ISQua, and we are moving to the 6th year. And this particular webinar is very, very pertinent because the WHO's current patient safety challenge is medication without harm. So we all know that medication errors, they remain among the most preventable causes of patient harm worldwide. And despite technology and protocols and guidelines, errors still happen. And why they happen in your own hospitals, across India and across for our members who are joining from different parts of the globe, we know that it is a system failure. So today's webinar is going to be on designing medication safety as a system, where we are going to look at how we can reduce the blame approach to develop a human factors-based design and a high reliability system. And to give us a very insightful talk, we have a distinguished speaker today, Dr. Rabih Dabliz. He is the founder and CEO of Aminia in Abu Dhabi, and he was the former senior manager of quality and medication safety at Cleveland Clinic, Abu Dhabi. Dr. Dabliz brings with him experience of deep operational experience of developing high reliability medication safety systems. And we are really looking forward to hearing from you, Dr. Dabliz, on how medication safety could be built as a systems in hospitals, not only in India, but across the globe. Over to you, Dr. Dabliz.
Thank you. Thank you, Dr. Subhrojyoti, for the warm introduction. I will do best. Good afternoon, everyone. And again, thank you so much for the warm introduction. It is truly an honor to be part of the first session for 2026 and seeing the whole list of the distinguished presenters and speakers. It's a lot of big shoes to fill, so I will try my best in today's session. So whenever I begin a session around medication safety, I always try to think about the why. What is the reason why we're here? What is the reason why this is a very important topic for all of us to discuss? And what we know as healthcare providers, we have all witnessed how healthcare over the years have become better, but also more complex. And we are surrounded by extraordinary innovations that are helping patients live longer, and they're living better. But what we also see that with this increased type of complexity means we have a higher chance of things going wrong. And when things go wrong, we all know what are the possible outcomes in the healthcare system. And like Dr. Subhrojyoti had mentioned, medication safety is a global patient safety priority, and it has been recognized by the World Health Organization through two major initiatives. One being the Medications Without Harm, and the second one being the Global Patient Safety Action Plan of 2021 to 2030. And there was a recent review that was done in 2023 where they looked at about 100 studies around covering 500 million patients worldwide in both high-income and low-income countries. And they found that 50% of preventable harm was due to medications. So 50%, that is quite the number. And in the same review, they also found that about 1 in 20 patients are harmed from preventable errors. What they also found in the same study is that preventable medication-related harm was nearly double in low and middle-income countries compared to 4% in the high-income countries. What else did the study show? It also showed that preventable medication-related harm was highest in the African and the Southeast Asian regions, about 9% each of them. However, they did show a lower Eastern Mediterranean region, but they believe that some of the studies were not sensitive in detecting these harms. So they cannot rely 100% on the numbers of showing 2% in other areas versus 9%. Now, my question to you, so we talked about the why. So I always like to ask this question. What do you think an elevator, Miss Universe, and a hospital have in common? I'm going to check the chat. Actually, it's hard for me to check the chat, so I guess I will continue. Well, bad design is everywhere. We see it in our daily lives all the time. This elevator is a very good example. Dr. Manish Kohli, we used to work together at Cleveland Clinic Abu Dhabi, and when this mall opened near the hospital where we work, almost everyone that I spoke to complained about this elevator. I mean, if you look at the design of it, it's very difficult to know which button you're going to press to take you where. Well, if you press the wrong one, the consequences are small. You get off on the wrong floor, no big deal, and then you try again. Another example of bad design happened in 2017 when Steve Harvey, a TV presenter, announced Miss Colombia as the winner of Miss Universe when the actual winner was Miss Philippines. What was the cause? Well, according to Steve Harvey, it was really in the way the card was designed. If he announced the wrong winner, well, he was embarrassed. It was a bit of a publicity issue, but that's it. It stops there. But when we think about healthcare, if you are administering the wrong medication, if you have lookalike, something like if you try to administer atropine versus epinephrine, or you're administering insulin versus heparin, what could be the outcome? Well, we all know that it takes one mistake and a poorly designed system for a patient to lose their lives. And what I would like to invite you to do is think about an incident from over the years that could have happened either in your organization or that you heard about. And I don't want you to think really too much about what was the cause and who was the cause. I invite you to think about the people, about the patient, about a 17-year-old who was supposed to be graduating that never graduated. I want to think about the mother that couldn't see her child, or the grandfather that went into a hospital and never made it out. So design is one of the fundamental things that we have to focus on when preventing medication errors and maintaining a safe environment for our patients. One of the major incidents that happened in 2017 that received a lot of attention was the Charlene Murphy incident. This was a patient who was a 75-year-old. She was admitted with a brain bleed, and she was scheduled for a PET scan. She was very anxious, so she went, the radiology technologist went to the physician. They asked him to order IV midazolam. This is a sedative. The brand name is Versed. So the nurse in the radiology wasn't comfortable with it. So they've asked one of the nurses, who was also covering a student with her, to go and administer the medication. So she went to a very fancy device, an automated dispensing cabinet. And we always say technology is best. Technology makes things safer. But in that situation, the nurse went to the machine and she started typing VE for Versed. Well, the way the medication was configured in that hospital was that it only contained midazolam. It had the generic name, so she couldn't see the medication. What she ended up doing, she had an option to override the medication, and she did, but she ended up pulling medication vecuronium, which we all know is a neuromuscular blocker. She pulled the medication out of the vial, administered to the patient, and the patient became unconscious. A couple of days later, she died due to complications of her having brain anoxia. And the result was also on the nurse, who was found guilty of accidental injection death of a 75-year-old patient. So an individual lost his mother, and a healthcare provider was coming to work to do her best to take care of a patient, ended up losing her job, and also probably being scarred for the rest of her life. Because none of us in healthcare is here to cause harm to patients. We are here to actually take care of our patients. And what we always know, when errors occur, sometimes, unfortunately, one of the first questions that we see or we hear by leadership is, who did this? the focus is always on who did the mistake, when it should be, why did it happen? How did it happen? And how can we prevent it from happening again? And also going back to what Dr. Subhrojyoti was saying, looking at things from a system level. And if we want to understand a little bit more how errors occur, there are two things that are usually happening. There's always a system component, and these are the latent conditions, or these are the latent failures that are happening in a system or in an organization throughout time that have not been picked up. And then there's a human component, which is the active failure. Unfortunately, we always blame the humans, and we neglect looking at the system, which is where the fix should always be. If an error is happening more than once, then we definitely know it's something that has to do with the system, not the human beings. And we all know this from James Reason's. I'm sure you've all heard James Reason, Dr. James Reason's, Professor James Reason's, and the Swiss cheese model. And what it is, we have a lot of holes in the Swiss cheese or in the process, and then a failure happens, keeps on cascading, reaches the patient. And we will always understand is that the system has allowed something like this to happen. So why do humans fail? Well, there are mainly three factors. Physical, if you're working a long shift, you have night duty, you have a reduction in alertness or in reaction time. You are sometimes having sensory limits. So you have difficulty distinguishing between lookalike vials, especially if you have very tiny print on the label, if you have poor reading conditions, and if you've had some issues with handling some syringes. And I'm going to give an example in a second. Cognitive, if you have multiple interruptions, it takes about 35 to 45 seconds to come back to focus after you've been interrupted. Sometimes there are memory limits. I mean, how many policies and procedures can you remember? How many protocols can you remember? And then there's also decision fatigue. If you've been working a 12-hour shift, or if you've been working even longer than that, the more decisions you're making, the less likelihood you are going to be making the wrong decision. And of course, cognitive overload. And the third one that we know is organizational. So what are the policies in place for the nurse-patient ratio? Do we have excessive overtime? Do we have policies that are in place that are non-workable? There are a lot of workaround on them. How we involved the caregivers and the frontliners, or the individuals that are doing the work, to actually be part of the process in designing it. So here's an example of physical factors. So if you look at some numbers, for example, in India, the average height of a male is 165 meters, and the average height of a female is 1.52. However, the average height of the automated dispensing cabinet is 2 meters. So you are designing a system. We ran into this issue in my previous organization. We had a lot of nurses from the Philippines and from India. And some of these automated dispensing cabinets were designed for nurses that were working in North America. So when the vendors brought those products in, they did not account for the difference in height between the various employees that would be working in those organizations. So we had to bring in some footstools, but that is a less than ideal solution. So the question always happens, where do medication errors occur? So in the same review that was published by WHO from 2023 that was looking at the types of harm, they found that approximately 53% of all errors happen at the prescribing component of the medication use process. And this went up to 78% in low and medium income countries. They also found the second was 36% in documentation and monitoring. However, from experience, I know administration is also one of the higher ones, especially in an organization that are not using infusion pumps, in an organization that don't use independent double check, and are not using barcode medication administration to prevent errors from happening. So there are some biases in the way that study was conducted. That is my personal opinion from experience over seeing more than 20,000 medication safety events over about 10 to 12 years. So now I'm going to introduce very briefly the SIPES model. So the SIPES framework it's called the Systems Engineering Initiative for Patient Safety. And the fundamental idea behind the SIPES model is that safety really emerges in how people, tasks, technology and tools, the organization and the environment interact to produce outcomes. And this is essential to understanding medication safety as a system. So the people are in the center. They can be the staff, the patient, and also the caregivers. It can also be anyone who is involved with the patient inside the hospital or outside the hospital. Technology and tools. And the essence of the CIPES framework is that the work system, which we just discussed, will impact the process, and the process would be the work that is required by the staff and the patient, whether cognitive or physical. That could be prescribing, administration, preparing the medication, double checking the medication, loading the medication by technicians into the automated dispensing cabinets, and some of the social behaviors. What are the things that we allow to happen in the organization? So system affects the process, affects the outcome. And the outcome can be on patients, on staff, and on the organization. And this is the same framework that has been described before by Dr. Dabliz, which is a quality and patient safety framework, where you have input, process, output. And then there's that feedback loop mechanism where, based on the outcome and the process, goes back into the system, and it becomes a cycle that keeps on rotating. So the solution around this is always thinking in the terms of human factors engineering or ergonomics. These are two terms that we use interchangeably. One of my favorite definitions from Dr. John Gosby, he describes it as the discipline that studies human capabilities and limitation. So what are the things that humans are able to do, and what are the things that humans are not capable of doing or are doing with limited capacity? And it applies that information in designing a safe, effective, and comfortable system. So that could be in how you design your order sets, you design your infusion pumps, or any type of interface where the caregiver is working with a device. So to simplify it, really, human factors when you mix psychology and engineering. So what does that look like in healthcare? That looks like when you are designing your crash cart drawers for you to have, consistency in how you standardized information at crash cart. It's used when you're looking at how you store and dispense medications. So the screen that the caregiver is interacting with, how are you segregating your medication in an automated dispensing cabinet? Are you using lids? Are you using labels? Are you requiring scanning? Medication administration. So that would be how do you design your infusion pumps? Preparing labels. You don't have to be having labels that are made in pharmacy. It can be labels that you have designed. And I will be giving examples on a recent project that we worked on that we will make available for free as part of work with ISOP. Tools and references are things that you'll be applying it for. All of your workflows and procedures involve human factors. You want to design a workflow that works for the people that are doing the work. And then technology assessment, and then finally information display. And I will be giving examples of those towards the end of my session. So how do you approach this? Well, the WHO, as part of the Medication Without Harm initiative, have come up with a system level framework. So they were looking at 3 areas of action: high-risk situations, polypharmacy, and usually polypharmacy, you see it in older individuals, and when you have people which have multiple chronic conditions and comorbidities, and then the third in transition of care. And of all of the areas that I have seen in in the organizations that I've worked on, transition of care has been one of the bigger ones, especially, we have a lot of focus on medication reconciliation. We want to make sure patients are moving in the right way through the system, but there are always times where we drop the ball and error happens with transition of care. And the framework, and I will not be going into the details of the framework because it is quite a comprehensive framework, and maybe we'll have a separate session around that in the future. But it looks at 4 domains. It looks at patients and the public, healthcare professional, and what are the resources that you have to make sure are available for them. System and practices of medication. This is more the system level design that we were talking about. And then medicines, where you focus on making sure that you have good quality medicines. A lot of the errors that they saw in some of the countries in Asia and Africa were issues with medicine that were falsified. It's particularly in antimicrobials and antimalarial drugs, where they were not effective because there's a lot of falsification. And even recently, we've seen a lot of falsifications with Wegovy, with Saxenda, with Mounjaro, where so many of these products were on the market, basically looking identical to the medication. Okay, so you tell me, worst case scenario, if Mounjaro does not work, then people don't lose weight. But if you have someone who has received a vaccine or received an antimicrobial and those are not working, well, there are definitely long-term repercussions and even short-term in patients that are septic. So examples of some of the tools that are available from WHO to raise public awareness in medication safety, there's a no check ask. This is a tool that allows, this very simplifies for the patients what they need to think about when they are asking about their medications. There's also another tool for patient engagement. This is also a tool that was developed by WHO. It's called the 5 Moments of Medication Safety. And then it looks at, when starting your medication, when you're taking it, when you're adding a medication, when you're reviewing your meds, and when you're stopping them. So these are a series of questions to make sure the patient understand. There's also a similar tool that was developed by ISMP Canada several years back. It's available in 15 different languages. This is English, and this is the Punjabi version that I found, but there's also an Urdu version that is available. So now, if you want to look at things also from a system level perspective, ISMP Canada and ISMP USA, which is the Institute for Safe Medication Practices, they have a framework, or we call it the hierarchy of risk reduction. So basically, these are the 3 different tiers that we want to look at when we're looking at solutions. The first one is high leverage. These are the ones that are the most effective, and we call those forcing functions and constraints. For example, would be removal of a product. So when the Joint Commission International and WHO came back and said no concentrated electrolytes, particularly potassium, we saw a significant decrease in patients that died in almost every organization that had a concentrated electrolyte on any death that we saw with potassium chloride that is concentrated was related to it being stored. The minute you don't store it on the unit, you have a much lesser chance of that error happening. The second approach would be automation or computerization. We understand that technology is a great tool to have, but at the same time, we understand the limitation. We understand a lot of the resources that are required to purchase the technology, to assess the technology, to configure it, to maintain it, and then to use it, and then to recycle it back again. It's a whole ecosystem. So don't think that you're necessarily making things safer if you're introducing a technology when you don't fix the process. If you have a bad process, technology is just going to take a bad process and make it happen quicker, and you have a quicker distribution of harm happening. So you always have to make sure when you're introducing technology, you're doing a failure mode and effects assessment. You're doing your risk assessment to identify what are all the things that can go wrong, and work with the frontline team. You want to do your usability testing. You want to work with the frontliners to help design how that tool is going to be used in your organization and how to configure it. The second, which we call the medium leverage or moderately effective, is standardization. Like example would be standard concentrations, having electronic order sets so that everyone is ordering the medication in the same way. I mean, order sets can be also on paper. So if you're an organization that has not introduced yet electronic health records and computerized prescriber order entry, you can still use ways where you can actually configure your order sets to be used in an efficient way. Reminders, double checks, and all of that, independent double checks is an example of the medium one. And then the low leverage is policy and procedures and training and education. Unfortunately, sometimes when an error happens, we blame the caregiver and we do training, education, but without really understanding what was the source of the issue and really trying to fix the process. So policies and procedures are very important. They are the ones that drive how we do the work, but then you introduce high leverage to make sure that they are implemented. So for example, if you want to safeguard against, if your policy says a nurse is required to be at the automated dispensing cabinet to remove a medication, then you configure your automated dispensing cabinet to require a second person to be there. I'm just giving this as an example, but policy tells you how to do the work, but then you can introduce technology to do the forcing function. And everything has to do with your resources. We understand that depending where you are in your journey within your organization, you have limited resources. So then it's up to you to determine which is the introduction or which technology you would like to introduce first. So I'm just going to give you a couple of examples of the things you can automate. So when you're doing selection procurement, so with your pharmacy and therapeutics committee, you can do automated replenishment. You can use now artificial intelligence to look at your PAR levels and minimize expirations. In terms of physician prescribing, introduction of electronic health records and clinical decision support. So if we know that the majority of errors that are happening in both low, medium income countries and high income countries are in prescribing, then if you have limited resources and you are wondering what is the first technology that I might want to introduce to prevent errors with medications, then you might want to consider electronic health records, because it also allows for continuity of care and making sure everyone has access to information. With order verification, you want to introduce auto verification sometimes in areas that don't require pharmacists to review a medication. In preparation and dispensing, you can have packaging dispensing robots, automated carousels, IV admin robots, and IV workflow. Again, I understand resource restrictions depending on where you are geographically, but the idea is you are the ones who will determine what is the best solution for you. But those are just a couple of examples of what is available. For transport would be automated dispensing cabinets and radio frequency ID. For admin, infusion pumps are in the introduction of infusion pumps with, we call them the smart IV pumps, have had a significant improvement in reducing medication errors due to administration and wrong programming. And barcode medication administration also had significant improvement in preventing errors with administration. And from my previous experience, almost every time that we saw an error with administration was because either the medication was never barcoded prior to administration, or after the nurse administered the drug, they decided to barcode it to scan it, and then that's when they found out that they have administered wrong medication. So to end my talk, I'm just going to give a couple of examples of what I call them. Well, I don't call them, I call them the 5 information rights, but they're based on what are called the 5 rights of clinical decision support. And the idea is that you want to provide information to the caregiver as close as possible to where they are performing a task. So if it's something that has to do with prescribing, you place the information in the order entry screen. If it's administration, you can place it in the room where the patient is doing a procedure, or you can place it depending on what resource you have. But the premise of idea is you want to have the right information developed by the right person for the right person. You want it in the right format, whether electronic or on paper. Is it a poster? Is it a leaflet? Is it a text message? Is it a QR code? Through the right channel, and then at the right time. And what I mean by the right time, as I mentioned earlier, is that making sure that you're providing that information when they are needing it the most, immediately prior to doing the work. To keep it simple, you want to, the key design principles when you're designing information, always place important and frequently used information first. You want to group it by functionality. So prescribing first, how to mix, and then how to administer. Think about the sequence of a medication use process. Visualization. Information should be easy to interpret. Caregivers only have a couple of seconds to read through a policy or through a order entry screen or through an administration label. So you have to make sure the information on that label is very easy to read and the sequence they need. So a couple of examples. Here's an example of automated dispensing cabinets where you place, let's say here in brackets, the type of medication that it is. We use Tallman lettering to distinguish between lookalike and sound-alike medication. On the right side of the screen is an example of, a lot of times people say high alert medication, you have to place a label, place a label, place a label. The problem with over-labeling medications as high alert, you have alert fatigue as well. So one solution, if you have an automated dispensing cabinet, you can actually place that information for the caregiver at the screen before they remove the medication. So in this screen, you're already telling them that this is a concentrated medication, it requires dilution, it's a high alert, and requires independent double check. Because the thing is, this is configured at the system level. You don't have to rely on a pharmacist or a technician remembering to place a sticker on the label. Here's an example also of designing information based on the end user. So if you are a physician who is about to prescribe, let's say, a fentanyl PCA, the physician is interested in knowing the dosing and how do I dose this medication and how do I provide the info to the nurse. But if you're a nurse, you're interested more on how do I program the pump? What is the type of code that I'm using? What is the type of syringe I want to use? What is the type of tubing? And then if you have a CPOE system, this is why I always recommend start with an EHR. This is an example where you can also here embed in the link section references for the caregivers. So if there's a policy on how to use PCAs, it's there. If there's a job aid, here's an example of a job aid that we created in my previous organization to tell nurses on how to, what are the things that are required when documenting PCA on the MAR. So that was a visual tool that helped them know exactly what needs to get done. So you're bringing the policy as close as possible for them when they're doing the work. This is an example of a tool that was developed for pharmacists for them to remember what are the things that they need to do when dispensing a medication and how to resolve a issue with a printed prescription. Again, it's a visual. It's placed on where they do the work to remind them. This is an example of an IV guide for administration of medications. So this is a digital tool, but you can also do it on paper. It tells nurses which medication, where can I give it, and can I give it IV push? Can I give it continuous infusion? It requires some initial design, but it also does not require you to have technology that is very highly advanced. This is a tool that you made available to your nurses on your units. Here's an example of something a little bit more complicated where we had in one guide for stroke patients telling you these are all the requirements before you administer, shows you the dosing instructions, visuals on how to mix a drug. There's a QR code that takes you to the medication, show you how to mix it. This is able to show you a double check and then screenshots infusion pumps. It really depends on your resources, and based on those, you can develop various tools. But again, this is an example of placing in one area all the information that is needed. So a couple of last examples. This is of pre-printed labels that are used as part of the stroke group. This is an example of a guide that is used for nurses, telling them how do you know that this is a high alert. We use the PINCH acronym to remind them of what are the high alert medications for the organization. It's up to you. Everyone asks, it's up to you as an organization to determine what is your high alert list. It can be depending on previous errors that you have seen in your organization, but also could be also dependent on external events that have happened either regionally or if there's something that's coming on from the regulatory side within your country. Here is also an example of the label that you see in the middle is a tool that we will make available for anyone for free. This is a standardized label that can be used anywhere. It contains all of the elements that are required to have a safe medication information on a label. We created two versions, one that is for regular medication and the one is for high alert. And then the example on the left is if it's produced by pharmacy, it's designed in a way to show you information in the sequence that will be used by different caregivers. For example, I want to know first who this is for, but the patient information, and then the drug, how to dose it, how to store it, and then for how long can I hang it. So again, this is an example of how you sequence information by priority. And the last two parts this is an example of a tool that created for warfarin. What we did, we made it available as close as possible to the caregiver, to the patient. So we created a sticker with a QR code that when they scan it, they can watch the video. It's a printed handbook, and then they can watch it as a video. The nice thing about this tool, and I can provide you with the link, we created this in 4 languages: in English, in Arabic, and Hindi and Urdu. The reason behind that is because we found that a lot of our patients that were coming in were Urdu and Hindi speaking. So we wanted to make sure that this tool was available for them in their own language. We had more than one incident where, because English was not their primary language, they were having difficulty understanding our old, very basic printed material. So I'm very happy to share those tools with you. And now I'm going to end with a 1-minute video of the video in English, but you will have the Hindi and Urdu versions available to you.
So do we have any audio for this video? We can't hear anything.
You cannot. Okay, sorry. Let me reshare it again with sorry, I'll reshare it again with the audio.
The captions are quite
No, I will
instructive. No problem.
Hello. You're about to start taking
This is better.
warfarin, an important step
Yes,
in
sir.
keeping your blood healthy and preventing clots. We're here to help you with 10 tips to use warfarin safely and effectively. Take warfarin at the same time every day. So if you miss a dose, take it when you remember, but never take more than 1 dose per day. You can take warfarin with or without food, but if it upsets your stomach, take it with a meal. Keep your vitamin K intake steady by eating leafy greens in moderation and avoiding big dietary changes. INR tests ensure you are taking the correct dose. Initially, check it 1 to 2 times a week, then every month, and remember always to attend your appointments. Inform healthcare providers you're on warfarin at every visit to the hospital. Don't take medications without your doctor's approval, especially anti-inflammatory drugs. Never stop warfarin without your doctor's advice. Use a soft toothbrush and an electric razor to minimize bleeding risk. If you are pregnant, consult your doctor immediately. Seek emergency treatment if you have bleeding from a large cut or a small cut that doesn't stop in 10 minutes. Please reach out to us with any questions. We are here to support you.
And with this, I end my session. Thank you.
Excellent presentation, Dr. Dabliz. I think this was a very comprehensive presentation talking about the systems approach, and something which really was highlighted is the engineering aspect of the system support, that when we are building our systems, we must ensure that, we have safe systems in place, especially the one which you mentioned about the systems engineering framework, patient safety framework. This is something which is very, very highlighting. I think another very important aspect which came out in the last part of your presentation is that medication safety involves a lot of engagement with the patient. So this kind of video which is highlighted in our regional languages, especially in India, can actually go a long way to talk about the high-risk medication. Let me see if there are any questions. I don't see. I think you've explained the topic so really well that there are not many questions here. People are talking. People are actually giving you feedback about your inspiring talk, and everybody, I think they really want to get hold of your excellent PowerPoint.
That's right.
Which is I think a very, very self-explanatory PowerPoint. I have a question to you, Dr. Dabliz. There is always a question that automation is better than the humans in with respect to medication safety. What is your take on this? Do you think if robots are installed and automated medication experience systems are installed in hospitals, can we do away with these our human factors, or can the human factors still perceive? What are your thoughts on this?
So thank you for the excellent question. And you're asking whether we can get away with only relying on automation. At the end of the day, automation is here to save, is to serve humans. It's called the human factor. So it's about how do we design tools that are made for humans, keeping in mind their limitations and then their capabilities. So I definitely believe in automation as being used so that we can give caregivers, pharmacists, more time at the bedside. So if I have automation that's helping me prepare medications, loading them to devices, everything, then I'm giving more time for the pharmacist to go and do the clinical review. The pharmacist has more time to speak to the patient. The pharmacist has more time to spend time at the bedside, which is what we're trying to do. The more time caregivers and healthcare providers have with patients, the more the opportunity to engage with them, and the more they're able to explain to them about medications, understand their concerns, and also pick up on potential errors that are happening. So definitely it's good to have both. The automation will not remove the need for pharmacists. It will just shift where we want to use our pharmacists, and that would be at the bedside where they belong, instead of having them spend too much time on things that are more technical and physical labor.
Thank you. I think that's a very candid thing, that both complement each other, that we need, highly efficient human minds, which are complemented by the automation process. I completely take that point. One of our participants is asking, how do we monitor this process? I mean, in terms of the process of medication safety implemented at the systems level, what should be the monitoring process? What should it involve?
So there are multiple things when you're looking at medication safety. It depends on the process. So for example, if you when it comes to, let's start from the beginning. If we are looking at replenishment of medication, we're looking at medication selection. We can look at what is the cycle? Like, how frequently are we ordering medications? Because that tells us how our system is working. If we've done our par levels correctly, we're not doing multiple orders. We're not running into a lot of wastage of medication. You can track how many medications are being returned from the nurses because we have too many stat orders that are coming up. So if I have too many stat orders and not used and coming back to pharmacy, that means there's something wrong with how am I dispensing? How am I doing my cart fills? You can look at percentage of scanning at the nursing level. That tells you multiple things. One, are nurses using medications? Are they scanning them before administration? But also that allows you to also make sure, am I labeling my medications correctly? Because sometimes what happens is that you might have a barcode label designed by pharmacy, but if it's on a paper that is very hard to scan, if it's affected by the fridge, and then you might get a lot of moisture, the nurses don't scan it. If it smudges, all of these things that allow you to go back and see, assess your different processes. So, and that's a whole different section. And maybe that one session we can talk about KPIs. What are the KPIs that I'm looking at to look at my operations? Because you're looking at operational information about med safety, and also information about finance and the financial health of my pharmacy department. But if the question I always get asked, what do I start with? Like I mentioned in the presentation, start with an electronic health record, because one, it allows you to have access to patient information, and also it automatically allows you to have a medication administration record that is electronic. So you have less reliance on nurses transcribing information from the physician order onto a piece of paper, because that used to be one of the main also causes of error. And then administration, which is then introduce barcode medication administration, and then introduce infusion pumps that'll have infusion pump software. But again, it's all in design. I've been in organizations where they've bought these very fancy pumps, but they're not using the library, or they've designed the library in a way that people are always selecting the wrong entry in the pump. So we have to be also very careful with how we use our technology and design it for our caregivers and for our patients.
Got it. So I think it has to be very contextual, is what you're saying, in
Correct.
terms of if we have the system, the people should be able to use the system. It should be user-friendly, as you're mentioning. We'll move
Designed
on.
by them.
Yeah, especially for the users. That's extremely important. Dr. Deepak is actually asking a question on how can AI and automation enhance medication safety in healthcare by streamlining dispensing while delivering accurate patient-friendly education.
Yes. So that was actually, so with AI, dispensing is good. So AI is still being studied in different ways for medication safety. I was in a talk in ISOP Egypt a couple of weeks ago, and there were some discussions around different patient education material that could be produced by AI. That is very, very promising. The important part is it still has to have a human factors that looks at it. So before, if I have an AI agent that is putting together a leaflet, one, I want to make sure it's consistent with all the other leaflets that's produced by the system. I want to use icons. I'm a visual person, so even if AI is putting together a leaflet for me, if it's all in text, and it's full of a lot of information that might not be necessary for the patient, then also defeats the purpose. So I really caution people about over-reliance on AI. There's a lot of people that are trying to sell you AI solutions that are nice and fancy, but the question always has to be, is that solution really answering the problem that I have? That's the thing to always look at. AI can be very helpful in detecting medication errors or adverse event following an overdose. So if you have an AI agent that is going through your electronic health record and notices that you have been giving dextrose, or you're giving, the IHI trigger tools. So it's looking for administration of vitamin K, it's administration of flumazenil or naloxone, then that come back and tell you, well, there's a high chance that this patient might have experienced an adverse reaction or adverse event, because now I'm seeing more reversal agents, or I see a subtle drop in platelets, or that could be a sign of either an overdose or a med error. So AI definitely can help us with trends and picking up warning signals for us to investigate further.
I just want to add to that, it also has to be very, very geographically validated because, especially I would say something which is extremely developed in the Western world. When it comes to India, we need to actually validate, something which at CAHO we did for, medication administration tool, which we had validated in 18 hospitals. And I'm very happy to share that this just got accepted for publication at the ISQua's journal, that will be published in a short while. I think we'll end the session with one last question. This is from one of our participants from Saudi Arabia. And the participant is asking, can you explain the role of hospital culture to effective implementation of medication safety? How important is hospital culture? We'll wind up the session with this question.
So there's always the saying that culture eats strategy for breakfast or for lunch or for dinner, however, in whichever country or society you live in. And that's what I firmly believe. It always starts with culture, and it starts with the leadership team. If the leaders understand human factors, if the leaders understand a safety culture and the components of a safety culture, then you are able to move forward. Because if you have a CEO who understands the importance of human factors, then he will make sure that you have the right resources when you're selecting your tools or when that are available. What I ran into an organization that were very highly automated, and then when there's time to do cuts because of financial reasons, sometimes half of the IT team is gone. So if you are a very high IT and informatics organization, and then you're losing your IT team, then who's going to be there now to make sure that you have maintenance? So design and implementation of a system is only the first step. Maintenance is just as important. So you need to make sure that the leadership is on board. You want to have a safety culture, a just culture, and a learning culture so that people can speak up and people are comfortable saying, we need to stop and reassess what we're doing and not be taken by all these fancy tools. Because again, I've seen it so many times where a fancy tool, but is it really solving the problem or the issue that I have?
So thank you, Dr. Dabliz. I will just, take your last things that the leadership is very important to keep the learning culture on, which is there with the leadership at CAHO also, and also in ISQua, because they believe in that the learning culture should go on. And your talk is an, avid example, is a burning example of this. Thank you very much for your insights, and over to Dr. Lalu.
So thank you. Before
Lalu
comes on the scene, I'll just make a brief comment. So first, thank to Dr. Rabih Dabliz that all of you should know that he had an acute laryngitis and was almost devoid of his voice this morning, and we were having this conversation. But I am reminded of a very famous incident when our best singer Lata Mangeshkar, she had a bad throat, and then still she sang a song, and that was one of the best songs that she has recorded. And same way I'll say, Dabliz, that in spite of this thing, I think this has been one of the best sessions that we have had. So over to Lalu. Thank you, Dabliz.
Thank you so much, and truly appreciate Dr. Rabih Dabliz for joining us. I think, Dr. Dabliz, this is the second time we are seeing you online. We look forward to seeing you in person. April 10th, 11th, and 12th, and 10th, we have some pre-conferences aligned for you. And of course, 11th. So we are truly awaiting to see you in person. Thank you. And
thank you. Appreciate it.
Look forward to seeing you. Thank you so much. So let me take this moment to thank Dr. Rabih Dabliz, and I request Dr. Carsten to hand over the Certificate of Appreciation from CAHO and ISQua. This is the virtual Certificate of Appreciation. This will be emailed to you. Dr. Carsten, over to you for your comments and for handing over the certificate.
Thank you. And thank you, Dr. Rabih, for these excellent presentations. I'm very pleased to be able to hand this certificate over to you, not in person, but virtually, but I hope to be able to greet you in Chennai.
Thank you. Appreciate it.
Thank you. Thank you so much. And thanks, Dr. Subhrojyoti, for moderating.